All right, I guess I'm going to get started. Sorry about that. I'm having some technical difficulties here where I'm located. The hotel does not like me, it seems. So I got to restart a few things. Okay, hopefully everyone can hear me. If you can, please let me know. If you can't, well, then you won't let me know. My name is Jeff Thompson. I'm the Clinical Services Manager for Synapse. Thanks. I'm the Clinical Services Manager for Synapse Biomedical, and today we're going to be talking a bit about clinical aspects of diaphragm pacing. So, something about the device. The NeuRx Diaphragm Pacing System is intended for use in patients with stable high spinal cord injuries with stimulatable diaphragms, but lack control of their diaphragms. The device is indicated to allow patients to breathe without the assistance of a mechanical ventilator for at least 4 continuous hours per day, and it's for use in patients 18 years of age or older. And I'm just informed my screen is not sharing. So hold on just a minute. Let's see if I can get this to work right now. Okay. Can people see my screen?
Yes.
Great. Okay. So that's the slide you missed. It explains what the diaphragm pacing system is and its intended use. And next, device description. So the device consists of a couple of different components. First being the electrodes. The Permalock electrodes are the electrodes that are implanted directly into the diaphragm muscle using minimally invasive laparoscopic surgical techniques. Picture on the left of this slide shows how the surgeon inserts the electrode into the diaphragm, and then the picture on the right shows the electrodes after all have been implanted and then coming out of the patient's abdomen. It's important to remember that our system is a percutaneous system, so there will be about 2 inches of electrode exiting the skin at a predetermined exit site. The implanted electrodes are connected to the NeuRx external pulse generator. It's the device there on the left, through the patient cable and then the connector holder site. Picture on the right there shows how we connect patients. The EPG itself provides electrical stimulation to the implanted electrodes to cause the patient's diaphragm to move similarly to natural breathing. And that's important for a couple of different reasons. One is it's going to give the patient back a natural feel of a breath. They're going to be allowed to use their natural filter and their natural humidifier being their nose and upper airway. And it'll also could allow them, if they progress to being capped, is the ability to smell and taste better. This is a picture of the patient kit. This is what the patient goes home with or uses while they're in the hospital. As you can see from the picture on the right side of the slide, the patient receives 2 external pulse generators. Very similar to when a patient goes home on a ventilator, they receive 2 ventilators. We provide 2 devices just in case one may break or malfunction. Now to cover some of the do's and don'ts of diaphragm pacing, spinal cord injury patients must have a mechanical ventilator available at all times. If you feel that the patient is not receiving adequate ventilation or if any malfunction of the device is suspected, place the patient back on mechanical ventilation, or provide them a method of breathing. That could be an ambu bag. If they're using non-invasive ventilation, that could be that. But place them back on their breathing help and turn the pacing system off. Caregiver availability should be, and monitoring should be consistent with when a ventilator is used. Some of the don'ts. The Permalock electrodes and the external pulse generator are classified as MRI unsafe. So we are currently working on Permalock testing for getting the electrodes to be MRI either approved or conditional, but for right now, our entire system is considered MRI unsafe. Another don't, this is a flammability warning. Patients that have spinal cord injuries and have some type of skin issues, large decubitus ulcer, they may need some additional help with healing, and sometimes they're prescribed hyperbaric oxygen therapy. You do not use the external pulse generator in an oxygen-enriched environment such as a hyperbaric oxygen chamber or near flammable anesthetic mixtures with air, oxygen, and nitrous oxide. NeuRx EPG is not categorized as anesthetic proof. So let's talk a little bit about the patients that we use our device for. Patients with spinal cord injury, it's important to remember that no two injuries are the same. You can line up three C3 patients and they're not going to be the same. They could be complete, incomplete. They could have progressed to that point due to swelling or some other type of injury to the spinal cord, but they're not alike. So that's important to remember. It's also important to remember that the left and right phrenic nerves begin in the C3, 4, and 5 cervical vertebrae at the neck. The phrenic nerves are the line of communication between the brain and the diaphragm. So it's important for those to be intact. In order to use our system, the phrenic nerves must be intact, or at least partially intact. And this can be determined using a phrenic nerve conduction study, but the most definitive way of knowing if the diaphragm will respond to stimulation is through direct stimulation during mapping, and that's part of our surgical process. Patient selection. I'm going to talk about 3 different types of patients. The first being patients that are in an acute phase of their spinal cord injury. These are patients that are 30 days or less into their injury, still in the ICU, haven't been discharged for either LTAC weaning or been discharged to a spinal cord rehabilitation facility. Second types of patients are patients during their initial spinal cord rehabilitation phase of recovery. These are patients that are actually in a model spinal center or maybe a known spinal cord injury rehab facility. And then the third types of patients are patients that are months to years post-injury that are home and out in the community that somebody may know or may see in their clinic. First thing about all of this is, in my opinion, patients need to be motivated. They have to want to do this. Now, granted, I don't think they need to be this motivated. That's a picture of one of our patients that wanted to go skydiving, so he did. But they need to be motivated to get off the ventilator. You can't force them to do it. So patient buy-in is key. So during the acute phase of injury, these patients are implanted within the first 10 to 14 days of injury. And what this does is this does 3 very important things, and probably more, but the 3 I'm going to talk about are, it decreases time on mechanical ventilation. By being aggressive and treating them so early, you minimize diaphragm atrophy. Then weaning from the mechanical ventilator is done by setting the device and turning it on, and then using pressure support to maintain an adequate tidal volume. As the diaphragm is conditioned, you will decrease your pressure support because your tidal volume is probably going up. And then eventually what you want to do is you want to get the patient to CPAP or on a trach collar and wean them from the mechanical ventilator. And it's at this time when you get to that point, you want to consider a cuffless tracheostomy tube and introducing a speaking valve. It's important because this, allowing a patient to speak, especially a spinal cord patient that's lost all function and lost control of everything in their lives, by providing them just the ability to talk to us when we're caring for them, really improves their morale and gives them a sense of control of their own care. So it's important to consider that when they get to that phase. The other thing it does is once you wean them from mechanical ventilation, it opens opportunities for placement. No longer do they have to go to a vent facility. They can go to another type of facility that takes trach patients. And then the third thing about treating patients early on in their injury is that it's a cost savings for the hospital. Dr. Kerwin and Associates published a paper in 2020 that showed that they saved an average cost of approximately $144,000 per patient by implanting them early. Patients that are in their initial rehabilitation phase, these are patients that come to the spinal cord rehab and they're still on a vent, and they're being seen, if they're tested to see if they could be weaned from mechanical ventilation, along with going through all the rest of their rehabilitation. These patients can be implanted while they're in these rehab facilities. We have a number of facilities that we deal with that do this. They are weaned from mechanical ventilation in the same exact way. They're using pressure support to maintain an adequate tidal volume. The pressure support wean is drawn out a bit because of the amount of diaphragm atrophy. You have to remember that the diaphragm is a muscle that's designed to be used 24/7, 365. If it's not used, it immediately starts to become atrophic, starts to waste. Studies have shown that the diaphragm can become completely atrophic within 72 hours of start of mechanical ventilation. And this is for any patient. This isn't just for a spinal cord patient. So if you've got a patient that's been on mechanical ventilation 45, 60 days, you've got a lot of diaphragm conditioning to do. So just understand that these folks, some of them, it's going to be a drawn out process. It's not going to be as quickly transition from the ventilator to diaphragm pacing, but they will get there. And again, if you get them, and when you get them to that point where they're on CPAP or trach collar trials, those are the times to consider a cuffless tracheostomy tube and introduce a speaking valve. The third type of patients that I'm going to talk about are patients that are months to years post-injury. Our clinical study was done on these patients, and we recruited patients for the study that had been injured anywhere from 6 months to, I think the longest one was 20 plus years on mechanical ventilation at a home. We enrolled these ventilator-dependent spinal cord patients and used them as their own control. What does that mean? It means that to prove something to FDA and prove something in your study, you have to show that it works. Well, you turn the diaphragm pacer off, they were able to breathe. You turn it off, they can't. So they're their own control. What we found out was remarkably that 51 of the 53 patients that were enrolled in this study achieved a minimum of 4 hours of ongoing use of the pacing system and maintained adequate tidal volumes without the use of a mechanical ventilator. When patients got to 4 hours in the study, the investigators decided that, you know what, you can keep going. If you can use the device, you keep going. And many, many of our patients, almost all of them did, and were in some part of using the device more than 4 hours. Many reported using it 12 hours a day. But what we found is that 31 of the 53 patients were able to use the device to breathe without the assistance of a mechanical ventilator 24 hours a day. They weaned from the ventilator and they just kept going. The weaning from mechanical ventilation is prolonged because these folks are doing it at home. They're using their home caregivers. The good thing about that is they have a dedicated caregiver. So unlike in a hospital, when we're going to wean a patient using pressure support, and maybe you can't do that, but at certain times during the day, they had dedicated caregivers. And what they did is they simply would take them off the vent using a pulse oximeter, go as long as they could till they fatigued, pulse ox starts dropping, put them back in the vent, turn the device off, let them rest an hour, do it again. And they had the ability to fit in numerous sessions per day. Well, by doing that, you're conditioning the diaphragm. And what that did is that allowed the sessions off of the ventilator to become longer, and the number of sessions per day became less frequent. So instead of a patient doing 10 minutes off of the vent, they would progress to 12, 15, 20, 30, 60, 90, and then it just kept growing from there. So the advantage to that was we did have patients that progressed pretty quickly to getting off of the ventilator, at least to that 4 hours. But I'm not going to sit here and take a lot of time talking about it. We're fortunate to have Joel Vander Molen in with us for this, for our, whoops, that was the wrong button to hit. Hold on, please. Let's see, I lost my, technology is not my friend. Sorry about that. So Joel graciously offered to talk to us about diaphragm pacing. Joel is from Pella, Iowa. He was implanted in, I believe, November of 2010 at Northwestern University in Chicago, Illinois. Joel is the founder and primary programmer for Vander Molen Technologies, where he runs a technology business for websites, I believe. Joel also is the host of the Quad Life on YouTube. And Joel covers a lot of very interesting topics about being a quadriplegic, and including diaphragm pacing. And in his spare time, if he has any, he's also a minister, and a public speaker. So that being said, Joel, if you're ready, I can turn this over to you.
All right, well, thank you, Jeff. It's my pleasure to join everyone today. And yeah, as Jeff said, I am a high-level quad of C23. So in 1985, I was a typical 3-year-old that was bouncing along off the walls and did not like the word nap at all. And my family and I went to a trip in Des Moines, Iowa, and on the way we ended up having a car accident that I received my spinal cord injury at. And I was the only one in the car wearing a seatbelt and received C23 injury. So in the 36 years since, I've gotten used to life as a quad pretty well. And I use a lot of different equipment, but as of today, our interest is in the ventilator side. And when I was originally injured, my parents were told about a type of ventilator or pacemaker that was available, called a phrenic nerve pacer, but was also said that within a few years, it would really damage the person's nerves. So they did not want to go that route, and were given a choice of a couple of home vents, and they selected the PLV 100. And that's what I used all through grade school, high school, college, and for years afterwards. I was able to do a lot while on the vent, but of course it had its limitations as well. And around 2009, I was in one of the initial calls from Synapse about the pacemaker system. And at first I did not really like the idea, because I didn't like the thought of having an implant in me. But then after I kind of thought about it for a while, you know, it kind of be nice to be able to get off of the vent, and might make things a little bit easier. And so I worked on getting insurance approval for it. And since it was out of state for me, that I had to go to Illinois to get surgery done instead of being in my home state of Iowa, that took about 1.5 years of working with my doctors and everyone to get it approved. And I was finally given a 3-month window that I could schedule the surgery for. And it was done in November 2010, as just said, at Northwestern. So at the time I got the pacemaker, it had been over 25 years that I've been using the vent. and quarter century that my muscles had been used at all. So it took a while to get transitioned from the vent to the pacemaker. I was originally told that maybe by May of 2011, I would be on it for a half hour to an hour. But what actually happened is that around May, I was completely off the vent during the day and was pacing for 12 plus hours a day, closer to about 15 actually. And it took me probably another year, year and a half until I was pacing full time on it. Part of it was I had some initial problems with my wires getting damaged, because my wires are in a place that is easily bumped by my right arm, and we had some initial learning curves, to say the least, of how to protect everything. But it initially started working pretty well. And by 2014 or so, I was pacing 24/7, not using the vent at all, and it was pretty familiar of this system. Now, like with most things that are medical, be it meds or anything else, you have a long list of the good items and then an even more lengthy list of the side effects. But thankfully, that's not quite the case with the DPS, for me at least. As Jeff said, some of the benefits of it are natural breathing. For me, I use the speaking valve or the Casimir valve on the vent, and I, of course, never used my nose to breathe in. So at first, when I switched to the pacemaker, I could smell the toothpaste on my toothbrush when it was 3 feet away at my bedroom door. Had a very sensitive nose. And on the ventilator, I got used to it, of having limited battery life of about 12 to 14 hours in a single day, if I had it connected to an external car battery that we used. But for multiple days, that usually didn't work too well. And I like it now that the batteries and the pacemakers will last about 500 hours or 3 weeks. And there's a whole lot less equipment. So in my chair now, I don't need to worry about having a place for the vent and the tubes and everything else. I just have a small pocket behind me where my pacemaker goes. And of course, there's no noise of it. And it's a lot easier being in meetings and that kind of thing. I don't have the noise of the vent behind me. My PLV 100 wasn't that bad for noise wise, but especially the more modern vents now, they are quite noisy, I believe, and have a hard time when you're in a, say, quiet meeting. So that is nice. And also I don't get too blinds in the summer when I get out in the sun. But one big thing for me is that in early grade school, when we were starting to read out loud in class, I had it that with my vent, I could only speak for 2 seconds and wait for 2 seconds. So my teachers and my classmates thought I was having trouble reading, and no, it was just the case that I had to wait for my breath. Well, I got the passing ear valve about second grade, and then I could read circles around everyone else because I no longer had to stop and wait for air. I could talk nonstop if I wanted to, and greatly annoy my nurses and parents, which is also great for an 8-year-old. And I noticed when I had the initial meeting with Synapse that the person that was speaking had very long pauses between his breath. And that was one of the items that did not go over too well for me. And I hope that it was something that could be adjusted a little bit. And now that I've been on the pacemaker for almost 11 years, as you can tell, I've worked quite a bit to decrease the pauses, but unfortunately it's part of the system that I didn't realize. So for most of the time, I know how to hide them pretty well, but there are situations that it doesn't always work, especially at times when I'm dealing with such as type of mechanical things that are listening to me, or I have to speak to an automated service and say my name. Then it doesn't always understand me with the breaks, but it usually works pretty well. And living in Iowa, our main emphasis in this state is anything agriculture related. So the closest areas for me that I can go to for support are Rochester, the Mayo Clinic, or Chicago, or out to Lincoln, Nebraska. I'm hoping that as we get more knowledge of the DPS system, that more hospitals and areas will support it. I know that I work as much as I can to talk about what's going on with the DPS and promoting it wherever. So that is one area I would like to see change. And I know that Synapse is definitely working on it more often to do that. And as I said earlier, port and wire damage used to be a big problem, but with changes that have been made now, it's not nearly the issue it was initially when I started pacing. So that thankfully has been something that has been learned and is not really much of a problem anymore. But for me, one of the things that I had was that my trach was also starting to rub on my esophagus and my trachea, and it was starting to wear a hole in it. But now that I'm on the pacemaker all the time, I was able to switch to a trach button. And with that now, I don't have any problems with it rubbing in my trachea and no longer have pain from it or a hole. And so really due to that, I think that the pacemaker really has helped extend my life expectancy. I've heard of many long-term quads like myself that have had a trach that ended up rubbing a hole in their trachea that caused them to bleed to death quickly. So I am still able to get on the vent if needed. It's not very easy, but it is a possibility, and can easily suction through the trach button as well. But that has been pretty well my experience with it. I know that at first my mother especially was not real keen on switching from the vent because it was something that we were used to, and she didn't want to rock the boat, so to speak. However, now that it has been several years, she has liked the change. I know my caregivers have as well. It's like easier for them, especially now that I transfer back and forth from bed to chair. And so therefore it's something that has greatly improved my life, I would say. And now I do disability awareness talks at colleges quite a bit, and go to churches that I speak at and different things. And it has really enabled me to do a lot more. That's about been my experience thus far anyway.
Well, Joel, thank you. I do appreciate you taking time out of your day and talking here about your experience with diaphragm pacing. Joel, as he mentioned, since 2010 has been using our device, and that's quite a long time for somebody to show this much success and basically motivation, if you will. I keep talking about the word motivation, but Joel's definitely one of those motivated folks that I look up to as far as when patients get spinal cord injuries and they really want to keep improving their lives. So with that being said, I'm going to open this up for questions. As far as the clinical aspects of diaphragm pacing, the takeaways I wanted you to understand is that there are 3 different types of patients out there. Patients that are injured in their acute phase, usually within their first 30 days, they're in a trauma ICU. Once they become stable, they're a good candidate for diaphragm pacing. Patients that go to a spinal cord rehabilitation facility, places like Joel said, like Shirley Ryan Ability Labs, Craig Hospital, Shepherd Center, those patients are also treatable as well as patients that have been in the community for months to years past injury. There's no reason for them to get lost in the system, if you will. They can easily benefit from this device. So that being said, anybody has any questions, feel free to unmute and ask away.
All right, I have one question here asking what advice would you give to new people thinking about getting a pacer? My advice is first to see what kind of environment they have. If they're in an area that already has support or is close to it, that is very helpful. For me, I got advice from another quad friend that used a pacemaker, and he gave me tips on how to transition. And so somewhat having a peer or someone that can connect to helps a lot. Also, what is their environment like, that of how their home environment is for those that are more long-term, such as do they use a lot of computer stuff, and will the difference in speech affect a lot of different things? And how are they for caregivers? In 2014, I was pacing 24/7, but my insurance changed due to the Affordable Care Act. And they said that since I was no longer on the regular ventilator, my new insurance did not want to cover my nursing care anymore. And it took a lot of work between doctors, politicians, and others to finally get any of my nursing still covered. And it's kind of been a mess since then. But I was also told that if I was still on the vent 24/7, I still would not have I still would not have had coverage anyway. So
Wow.
it's kind of a sticky point that I'm sure if anyone here is used to dealing with medical insurance, that there's always a lot of stuff you'd like to do, but what you're allowed to do by insurance wise is always a major pain.
Yeah, I remember that talking to you back then when you did lose your insurance. That was pretty interesting. I wanted to ask the insurance that, did you have a cure for quadriplegia, because you're still on some type of breathing assist device. You still needed the help. Nothing really changed. But I'm glad things have worked out for the most part. Hopefully things will continue to keep going that way. Any other thoughts or questions, anyone?
And I could give you a video of me doing a zip line.
I'll take it. I will take it. Is that on your YouTube channel?
Yeah, I can show you here in a second. I forgot. Time for questions.
Yeah.
So,
you go ahead.
I'm sorry. Hi, I'm
Yes,
Dr. Galea. I'm the Chief of Spinal Cord at the Bronx VA in New York. So thank you both, and thank you for your testimony. It's fantastic. Just a couple of questions. So we haven't used the pacer in a while because we didn't have the opportunity, but we came across a few cases lately, and I was wondering if I can ask a couple of questions and see if you can relate to them. So the patient we have, first of all, are older, right? So you're younger, spinal cord injury patient, clearly more motivated, yeah, and that's certainly of notice. The patient we tend to have, especially here in the Bronx, tend to be 60, 65 is our average age, and a little older sometimes.
Mm-hmm.
So clearly, motivate them as is difficult. Also, I hear you, Jeff, saying at the very beginning that with the patient, like a lot of our patients end up in a nursing home because they do not receive the coverage, the 24/7, and they need to live at home. They don't have a dedicated caregiver. So it's possible to liberate them from the ventilator with the pacing and eventually, send them home, which would be fantastic. But the process needs to be done in the nursing home, and I don't know if you have any experience or is something that you have, have seen. And third question, I'm sorry to be so prolix, is that we have some patient that I'm thinking a couple of C4, C5, who actually never quite needed a ventilator. However, as they get older or the injury gets older, they tend to have a lot of atelectasis at the basis. So cough assist, vest does not seem to do the trick. And I'm thinking maybe the diaphragmatic pacer may help to actually provide the expansion of the lungs that they need to avoid that they continuously have need to go to the hospital and being put in the machine for the pneumonia and then off the machine and back and forward. Sorry for the lengthy.
No, you're fine. So I'm going to go from backwards to forwards on your questions regarding your C4, C5s that have atelectasis. Are they also vent dependent as well?
Not necessarily when they are well, but for example, I have a few that after living 20, 30 years, basically, of the vent, now all of a sudden they develop a pneumonia, they end up being hospitalized with acute respiratory failure, go on the ventilator, get treated, get off the ventilator, and it's becoming a circle. So yes. I'm trying to break the circle where, they can become less, prone to these kind of problems.
Yeah, and so those patients would definitely be candidates for diaphragm pacing. To be in more specifics, I could always connect you with Dr. Anders. He's our medical director, and he does more diaphragm pacing than anybody in the country. He could probably better speak to, is it better clinically indicated. Your middle question about nursing homes. Any patient that receives our device, we're more than happy to educate LTACs, nursing homes, families, home nursing providers, anybody on the device. And so if they've got motivated staff, whether it be respiratory therapists or nurses that are willing to take this on and help wean a patient off of mechanical ventilation on the device, especially if they could see how much better it makes their lives as far as caring for the patient, then I think that they would see the benefit of it. All we ever look for, whether it's in a hospital, LTAC, a nursing home, anywhere, is one champion, just one person that goes, wow, this is a great idea. Yes, we can do this. And then we feed off that enthusiasm, and we work with them to try to help them not only take care of their patients better, but make everybody's quality of life better. Whether it's a patient at home and the family's quality of life comes into play, because if they're on a patient, they can transfer easier. The same thing can also go on in a nursing home or an LTAC. They can transfer easier. It just makes things better for them all around. Your third question about age, without revealing too much information, the last two patients I've attended surgeries for, including the one today, they're in their 70s. And they are quite motivated because family is there, and they've gotten all the information. They've discussed it as a family. They realize that it's something that can help provide a better quality of life for their family member. And they go for it. They get implanted. So it's not out of the realm to think that a 70-year-old could benefit from this, especially at home.
And I have also had a patient that I mentored that was in that same age range that got a pacemaker a couple of years ago.
Okay.
Sorry, can I ask another question? Because I heard Dr. Ondes speaking a few times. I remember because you talk about diaphragmatic health, right? And the diaphragm being healthy, being, once we zap it, being able to contract well.
Mm-hmm.
Do you also do check the health of the diaphragm laparoscopically before you insert the electrodes, or not necessarily? Because I believe Dr. Ondes mentioned that at one point.
So during the surgical procedure, there's a part of it that's called the diaphragm. And what we do is we use a probe with an electrode, and we temporarily go around and map the diaphragm in a grid-like pattern. And what we're doing is we're looking for the best motor point to implant the electrode. So what we're doing is we're going through looking for this point. That part of it, I would just consider diaphragm health, if you will, because if the nerve is there, the diaphragm is usually in some pretty good shape. Whereas if the nerve is not there, the phrenic nerve is damaged, what we will see is diaphragm thinning. We will see the diaphragm turn gray. And in a number of cases, you can even see the diaphragm has become almost translucent, where you can see the lungs and the heart through the diaphragm. Well, if the diaphragm is that thin, implanting an electrode in it is not going to help. So yes, we do assess those things as well.
And my experience, when I got my pacer, I went out to Chicago, and a couple of days before a surgery was scheduled, I was tested by putting an electrode against the skin on my neck that then gave a jolt, and it then someone could see physically if my diaphragm reacted to it or not. And then I was also tested during the surgery. There was someone in surgery just before me to get a pacemaker, but it was found out that in the surgery that it did not work for him. So I ended up being the 7th successful person in Chicago, although I was supposed to be the 8th. So that is always a possibility as well.
Mhm.
That patient goes into it thinking that they can get the pacemaker, but it may not work.
Thank you.
Okay, so I received a quick note in the chat that there's a patient, a vent-dependent patient in an acute care facility that is not an SCI patient, just a failure to wean, and has been there almost 2 years. Can they benefit from diaphragm pacing? That would be a great discussion to have with Dr. Anders, he's the Chief Medical Officer of Synapse Biomedical, and also as he's co-founder of the technology. We are indicated for spinal cord injury patients. Now, we do have a temporary system that we use for patients that have ventilator-induced diaphragm dysfunction. Typically, these are patients from some type of surgery. But again, it's a temporary system that is approved through the emergency use access by FDA. But if you'd like to reach out to us, we can definitely put you in touch with Dr. Anders, and maybe physician to physician, this patient can be discussed. Anyone else have any other questions or thoughts?
If not, I have the video of his reply.
Oh, okay. All right, well, everyone, thank you very much. Truly appreciate your time. I appreciate you taking time out of your day to attend this. Please, if you have time, check out Joel's YouTube channel, the Quad Life. A lot of good information in there. Maybe refer some of your patients, and this, and along with other webinars that we've done, will be on the Synapse Biomedical YouTube channel. So if you want more information about diaphragm pacing, our YouTube channel has quite a few different talks by Dr. Anders and even Dr. Kerwin himself from University of Florida, although I think that talk, he was at University of Memphis now. So anyway, so go there and you can pick up more information. You can also email us, info@synapsebiomedical.com. And Joel, do you have anything you want to plug?
I think that's the main thing. I am available to speak remotely to people if you're interested as well. And yeah, I can be found at the Quad Life or joelvm.com. It's also a good place to get me.
Okay. All right, Joel, thank you again. I really appreciate your time and your ability to share your story. It's definitely one of those things that we probably don't share enough, and maybe we should. So thank you again. I truly appreciate it.
Yep. Have a great afternoon all.
All right, thank you, everyone. Take care.
Thank you for the presentation, and thank you, Joel, for sharing your experience.
Great. Thank you. Appreciate it.